Y'all haven't answered yet, right? Okay, what are some ways we can support her, did y'all say?
We said therapy, tell her the outcomes of what could happen, different options, like if she wants to go for.
Options.
Yeah, no, that's it. Yeah, those are definitely ones that we definitely want to tell her about. Therapies are really good. Get her in those support groups. Give her her options she has right now, and then do you have something else? Yes.
Because then they can give her an idea of how it's going to be. Just let her know that there's a plan that will give her her.
That's great. Did y'all hear what she said? Yeah, so you want to get her in touch with other parents. That's a really good one, especially parents who had good outcomes with their babies, because this isn't a death sentence for these babies. It's just a change in a parent's way of life, and dependent on the defect, it might not be that big of a change. There might be smaller amounts of neural damage. So getting her in touch with other parents is a really good option. Yes, ma'am?
You can also get her involved with case management so she can get assistance after the baby.
Yes, this is going to be a prime candidate for having a case manager follow her from this point through that child's life, because we need someone there who can be just follow up with her throughout it all, because if in this scenario we might be the clinic nurse who was there while diagnosing her, you know, so it's going to be a different nurse who was there when she got diagnosed to the nurse that's going to take care of her baby, and then the nurse who's going to take care of the, you know, further things. So that's a great one.
So can you tell, like, if they're going to have the worst one or the other one before they're born?
So on ultrasound, they can tell what type of elements are in that sac. So yes, so they more than likely should be able to determine what is in there and tell if it's myelomeningocele. Anyone else have any other thoughts about ways to support her? Yes, ma'am.
Is that something you can attempt to correct via a
Yes, and we are going to talk about that a little later. Good. Yes. No, that's a good one. That's a newer, fetal surgery is a newer development, and so we'll talk about that a little bit at the end. But that was very good. And then I think the other thing, we always want to let them express their feelings, finding out, and if you educate them on what this means, what this might look like, that mom might have a lot of feelings, you know, regarding that, especially if she's non-medical and you find out your baby's going to have a sac of their neural tube on their back. you know, we might be going through a lot of issues. So counseling, support groups, just education, letting them express their feelings. And then a little bit later in pregnancy, we might not want to overwhelm them immediately, but if they decided to keep the pregnancy and go along with it, a little bit later we want to talk about what it's going to look like after birth, what they're going to do for the baby after birth to try to get that surgery done, things like that. So just the most education we can give is best. Yes, ma'am?
Before they have surgery, can they lay their back?
We'll talk about that later, but if you think about it, what would you say? Good. Yes, exactly. No, because that is something we do not want to rupture. So, yes, ma'am. Once diagnosed, you know, I'm not sure. I can look that up though. That's a really good question. Ms. Osteen, do you know anything about that?
What?
Statistics of once women find out they have myelomeningocele about continuing their pregnancy or not. I don't know how you'd even get that statistic.
You'd have to break down therapeutic abortions and
Based
know
on.
exactly why they got them, and most people wouldn't be honest.
Yeah, that's true. That was a good question though. Yeah.
There's a cute little girl at elementary, if you did your community rotation, that has her. And she's fine.
How is she?
walks-
Yeah, what is she?
She's small and she's cute, and she just has to go to the nurse and get bullied every 2 hours.
Good. Okay, and she's walking everything.
She
Good.
looks
Yeah.
She's tiny.
She's shy.
Her mom would-
Good. Okay. So that's a good example of even if they have the myelomeningocele, if it hits at a certain point, they might not have paralysis. So that's a good representation of it. All right. Are we ready to move on? All right. So our next case study question, we're going straight into another one. And this is very similar to what you said, Ms. Kendall. So after working with her closely throughout her pregnancy, she comes in at 38 weeks for her scheduled C-section because with these babies, if you think about it, we're never going to vaginally deliver them. That is a big risk for infection, a big risk for rupture, so we're always going to have a scheduled C-section and before their due date so they don't go into spontaneous labor. So baby Emily is born and she has no other birth complications. So 2 questions here. What do y'all think is going to be the primary nursing diagnosis that the nurse should think about immediately after birth, but after she's stabilized? So she's in good respiratory shape. What's going to be our primary nursing diagnosis? And then what nursing care should she provide with positioning, with dressings? What would y'all think with dressing changes and assessment of the sac before she goes into surgery? Okay? Well, isn't they have another blood?
But it's not, it's before they close it. You can leave it. I think you would leave it. You don't want to add anything. But just leave it on the dry one, just leave it on the back.
So you want to do
I know, but how do you don't want to roll? Well, tell her what's going on, don't get in there. Let nobody, no,
Okay.
what you buy, leave on there.
You're doing a great job.
All right. We good here? What's your cousin answer? Y'all have an answer, right? Right. What are your, what do you think our primary nursing diagnosis should be?
Ineffective cerebral tissue program, and they, worry about blood flow.
That it, yeah, if it's higher up, yeah, we might have that issue, but even before that, what might you think with this sac on the exterior of the body?
Infection.
Yes, risk for infection. There we go. Because if this, there's already risk for infection having this there. If this was to rupture, we could get a lot of issues, meningitis, other really horrible bloodstream bacterial infections. So risk for infection would be our #1 priority. And then how would y'all position this baby? On this stomach, yep. What kind of dressings? Sterile, moist, exactly. How often are we going to check the sac?
2 to 4 hours.
Yep, 2 to 4 hours. Because you don't want to increase their infection risk by checking it. You are obviously going to wear what kind of gloves? Yes, because you want to make sure it stays sterile. So every 2 to 4 hours, we're going to be checking it, and you're going to be looking for leaks coming out of it or a straight up rupture. Because the second, if that sac starts to leak, our infection risk goes up tremendously. Good job. Okay, so we just talked about this, our primary nursing concerns. We have prevention of infection. We're also going to assess their neurological status. A lot of times these babies are going to be born with other associated anomalies, other neurological issues, syndromes. So you want to check their neurological function, check their reflexes, and assess them for any other anomaly they might have. And then we are going to be closing this sac as soon as possible. Surgical closure within 48 hours is going to be our goal time to get there, but as soon as possible. Okay?
Well, I have a question.
Yeah.
Sorry. She had mentioned there was a picture of the baby without the diaper on. So was that something like if it's low enough, you wouldn't do a diaper?
So if it's low enough, you're not going to do a diaper, and then a lot of times what we would do is roll down the diaper just so it covers the bottom area so you can clean it. Because you don't want the diaper touching it, but you also don't want any fecal matter getting up there. So you just have to find a way to, a lot of times we put a roll, and this was what we did in our NICU, put a roll, like a rolled up blanket, right down the middle so that they kind of laid around the blanket so that they were up a little and down, and that way their little bottom kind of slants downward at the end of the roll, and that helps that fecal matter to come out downwards as well. So.
Did you say you want to do, I know you do surgery as soon as possible, did you say within 24 or 48?
48 is going to be our goal, but as soon as possible. If you can get it done within 24 hours, that's what we'll want to do. You have to make sure the baby's stable. Sometimes if the baby is not stable, if they have a lot of other issues like respiratory issues or any other anomaly that's causing them to not be stable, then they'll postpone it, but that risk for infection will keep going up. So you want to get it done as soon as possible if they're stable. Okay? So her surgical closure went as planned, and now she's getting ready for discharge. What instructions and education should the nurse include for Miss Ashley, would y'all say, in regards to her baby's care and development? okay? So just for her, how we should take care of her and what her development might be like, okay?
So we just do the teacher at the time. Depending on, yeah, their age there. And so this, she still needs to make sure that the traffic No? Okay, is everybody good on that one? Okay. Okay, you got it.
Okay. As far as like the discharge instructions, we said to teach the mother about knowing the signs and symptoms of infection, when to report like to the doctor if she has any findings, and when to come to the emergency room or something. That
Good, yeah.
And then as far as teaching, you want her to demonstrate like how to do like a proper dressing change. And
Good. So what about some of those long-term effects we said this can cause? What might we want to teach mom about some of those? Milestones, good. Because with paralysis, I was just telling this group up here, if she does have lower leg paralysis, and we might not, they were asking, how do you assess that on a newborn? Well, it'll be reflexes, it'll be their ability to, we'll see if they're moving those limbs or not. But if they start trying to crawl and they're only using their arms, we might have more leg paralysis than we thought, things like that. But then, go ahead.
Also have to teach parents like how to straight cast and sit back.
Exactly. So these babies, when they go through life, one of the big things, and I'll go ahead and move this to the next page, is going to be their genitourinary function. These are often kids who are going to have to get, just like the one y'all talked about that you saw at the, was it the urgent care?
It was at an elementary school.
At an elementary school. So she has to go in for straight casts every so many hours. So in the hospital, we're going to do that with these babies. We measure intake and output very strictly, and we tell the mom and dad to do that when they go home. See what she's taking in. Has she peed in the last 8 hours? Has she defecated? What does her input and output look like? And then we're going to straight cast based on that. So that was our protocol in the hospital I worked in, was if not this amount of urine within 8 hours, we straight cast. And so a lot of the moms and kids are going to have to do that for the rest of their lives. So if you think about a teenager who was born with this and who has still has some bowel and bladder function issues, think about what issues they might have with their self-esteem, with having to go outside of the class to go catheterize themselves, because I've seen a lot of these kids, we want to teach them how to care for themselves, so they'll catheterize themselves, and so just think about bowel function issues if you're in a class and you lose control. So a lot of these kids can have self-esteem issues as they get older. So, all right, and then what about any type of family support? What could we tell mom about that? It's a little bit like what we talked about earlier.
Therapy groups?
Therapy groups are great. And getting the child enrolled in types of support groups with other kids who have spina bifida can be really good. That way they can be with kids who have the disorder, see how they're coping with it as well. But we also want to socialize them with kids who don't have it. We want to, they don't have any neurological deficits. They can be in the same third grade class as all the other third graders. So, are you going to ask something? And yes, they do camps for a lot of these kids who, for a lot of these kids who have issues. And spina bifida is a big one that they'll have the camps for. So, good. And then we also want to, remember what we said is an 80 to 90% risk with these kids? What was it? That y'all just talked about the other day. Hydrocephalus, yes. So we want to teach mom about what increased intracranial pressure could look like, signs and symptoms of that. If she starts exhibiting it, we probably want to come to the emergency room right away. Some of these kids will just automatically, it'll be diagnosed, they'll have BP shunts. So, yeah. Because of the hydrocephalus, yes. If they develop it, we want to teach them about it. But at first, you want to, a good thing to tell them would be if she starts exhibiting signs, if she starts having seizures, bring her in immediately, because that could mean hydrocephalus. She did, and she had seizures. Yes, exactly. How to do, yes, that's very good. All right. Okay, we're almost done with this naturally. We're getting close. So what discharge instructions related to allergies and allergic reactions should we include for her? This is a trick question. Not really a trick question, it's a tricky question. y'all feel pretty good about that one? I've heard a lot of people say what I'm looking for. So, okay, this group right here, what did y'all say?
Latex allergies, penicillin allergies, which is and they're having the infection. The types of tapes, whether they're using silk or paper tape, that turns irritate the skin.
Yes.
And teach the mother and the family the signs and symptoms of allergic reaction and anaphylaxis.
Yes, exactly. Yes, exactly. So we want to educate, we want to tell her about what we might see with the latex allergies, and that was a good addition to tape allergies, because they do have a lot of procedures, and that tape might cause an allergic reaction on their skin. But latex allergies is a really big one with these kids. Does anyone know what foods have a cross reaction with latex? Y'all looking forward?
Avocados.
Avocados, bananas. I'm not sure about strawberries. And then we have kiwi and chestnuts. Those are our big cross reactors, okay? So we want to tell mom, let's maybe stay away from those foods. If they do get exposed to those foods and have an allergic reaction, we know we have a latex allergy. So the reason that this is such a big issue with these kids is because they're so exposed to multiple procedures, multiple catheterizations, and they build up a sensitivity to those latex products. So what would we want to do in a clinical setting with these kids? Yes, create a latex-free environment. So most NICUs are going to be just a latex-free unit as is, because these are not the only babies who have a high risk of latex allergies. It's anyone who has high contact. So the cerebral palsy kids that Ms. Osteen was just talking about, if they have to have procedures done, they might develop a latex allergy. Yes, so our catheters need to be latex-free as well. Yes, exactly. Kids who have a BP shunt, because of all of the procedures, they might need latex-free or latex-free precautions. Yes, ma'am. They need to be latex-free. They do. They do. They do. They don't have them? Oh, yeah. Well, I'm not sure about adult world so much. They might not.
They're starting to.
They are? Okay. Yeah, because they might not need them as much. If you knew that this person coming in had spina bifida, you could probably find, if it was an adult coming into the emergency room, that would be something to trigger you. Maybe we should try to find latex-free gloves, but most pediatric units will have everything latex-free. Yeah. So, and then also just preterm infants in general, because if you think about a preemie, say they're born at 25 weeks, they are probably undergoing more surgeries than a lot of us combined will have in our lives. So just think about the latex precautions with them as well. Okay, so what can the allergic reactions look like? It can be wheezing, it can be rashes, or it could be as far as anaphylaxis. What they have found was that if the latex touches a mucous membrane or like wet skin or the bloodstream, then we get a worse reaction with these kids. And then we talked about the cross reactions. So we're going to reduce the exposure, like we said, and create a latex-free environment. All right. This is our last Miss Ashley question. So what would be important for the nurse to educate her about in regards to her future pregnancies?
Prenatal care.
All right, get in your groups and think about it. This will be a quick one, though. This will be a quick answer.
It may be a higher risk
Okay, we get it? Who's my last group that hasn't responded? No, there's someone out there. Back there? All right. She called you out.
The primary teaching would be folic acid.
Exactly. What are our normal recommendations for any women of childbearing age? 0.4 milligrams a day. Close enough.